Hello to everybody. Today we start to discuss about very important part of oral pathology, about white and red lesions of oral mucosa. White and red lesions of oral mucosa represent big group of pathological processes or conditions or diseases related with different etiology and pathogenesis. As you can see in this slide, we classify white and red lesions of oral mucosa between hereditary and unknown etiology conditions, different reactive lesions, different infections, and in this lecture we will focus with you in oral candidiasis and lesions with malignant potentials. First of all, we will focus in hereditary and unknown etiology conditions. And the first condition is leukedema. If you remember well, according to name of this condition, leuko, it means white. So, clinically, as you can see in this clinical picture, in the buccal mucosa, we can see whitish plaques or patches. Leukedema represents generalized bilateral change of the buccal mucosa. The etiology of this condition is unknown, and morphologically we will see just intracellular edema of non-keratinized squamous cell epithelium. As you can see in this slide, we see a lot of epitheliocytes with edema. This condition doesn't have malignant potential, doesn't need the treatment, and like a rule doesn't develop further. Second very common condition of this group is geographic tongue. You see in this slide the most typical clinical manifestation of geographic tongue. The etiology of this pathological process is unknown, more often encountered with women than men. The lesions change their localization from day to day, and for that we can see different area of whitish and reddish color in the tongue. Can be associated with fissurated tongue. I hope you understand what about we talk when we see in the tongue some defect. Again, this process doesn't have malignant potential and doesn't need the treatment. Fordyce granules. This condition is related with developmental conditions. As you can see in clinical picture, there are a lot of whitish dots in the mucosa, in the oral mucosa. It's related with the presence of normal sebaceous glands in submucosal layer of oral mucosa. This condition doesn't have malignant potential, doesn't need the treatment, and morphologically we can see just increased amount of sebaceous glands in submucosal layer, but morphologically these glands, they look normally. The next group of white and red lesion is associated with different reactive processes. Definition of reactive lesions. They represent changes that occur in association with chronic local irritation that can be a chemical product or mechanical stress. In this slide you can see the list of most typical or most common reactive lesions, And first of all, this is stomatitis nicotina, white lesions associated with smokeless tobacco, mucosa burns, and chronic mechanical trauma-related lesions. And first of all, this is marciata buccarum or buccal mucosa beating. Stomatitis nicotina. Stomatitis nicotina is associated with smoking. First of all, when we talk about pipe and cigar, and is characterized by appearance of the palatal mucosa and or generalized whitish spots with red dots in the center. As you can see in this clinical picture, the basis of lesion is whitish with a lot of small red dots. These red dots clinically are associated with inflammation of the ducts of minor salivary glands. The next example of reactive lesions is white lesions associated with smokeless tobacco. First of all, this is white lesions in the area where the tobacco is habitually placed. Smokeless tobacco could be associated or induced by Scandinavian snus. In this condition, this process is reversible after cessation of habits, or induced by Sudanese snus. The other name of this snus is tumbak, and these snus have a very high risk for further development to cancer. As you can see in this clinical picture, in the place where tobacco is placed, we will see whitish changes in the mucosa and the appearance of folders, whitish folders in the mucosa of oral cavity. The other process related with reactive lesion is mucosa burns. Mucosal necrosis in the area where the physical head, chemical substances or medicament is placed. As you can see in this clinical picture, the clinical appearance could be absolutely different. It could represent whitish patches in the surface of mucosa, or mixed whitish and reddish area. And the last example of reactive lesions is chronic mechanical trauma related lesions. First of all, marciata buccarum or buccal mucosa beating. Marciata buccarum is associated with mechanical trauma. First of all, beating or showing of the buccal mucosa. The tissue responds to friction by producing keratin and becoming thickened, and this process, if you remember well, we name like hyperkeratosis. Depending on the degree of trauma, the tissue may also become ulcerative and eroded in areas. The specimens is usually only noted as hyperkeratosis with surface bacterial colonization. So here in this slide you can see two clinical pictures with whitish area and some superficial defect in the area of trauma here, or just whitish defect here, and morphologically we see just hyperkeratosis with, if we will change for high magnification the slide, we can see colonization of bacteria. Sometimes we can see more deep defect, not only erosion but ulceration, like in this case. In the area of whitish plaque we see ulcer, and in this case it's necessary to take a biopsy because ulceration could be associated with malignant tumor, and for exclude malignant tumor we have to do the biopsy. So now we will talk about white and red lesions related with infections, and first of all we will focus in oral candidiasis. Oral candidiasis clinically represent white patches that can be removed by scraping on an erythematous atrophic mucosa. It's very important clinical sign or clinical tool for, first of all, suppose candidiasis. So I repeat again, I focus your attention that these white patches in oral candidiasis can be removed by scraping. So here we can see erythematous or reddish atrophic mucosa, and in the surface there are a lot of white patches. In general, candidiasis, you know well that Candida albicans is a normal component of oral flora. This normal component of oral flora becomes pathogenic in some conditions. First of all, in case of immunosuppression, in case of alteration of oral microbial flora, broad-spectrum antibiotics, for example, and finally it could be like one of the complications of treatment when we talk about antibiotics, nutritional deficiency and dry mouth. Clinically, we will see card-like cottage cheese, the synonym of card is like cottage cheese, card-like white patches that expose a reddish bleeding surface when stripped off. So here in these clinical pictures you can see these card-like white patches in the surface of oral mucosa and in the surface of tongue. Occasionally the disease may present just as red patches, so it means it's not necessary to see only white patches. Sometimes clinical manifestation could be only like red patches. Morphologically, we will see inflammation, but for a proof the presence of Candida albicans, HIFA, in the epithelium, we have to use additional staining. First of all, pus reaction. And here in this morphological slide you can see the staining with pus, in which we can see in the superficial part of epidermis hyphae of Candida albicans. Three major clinical forms of candidiasis of oral mucosa are distinguished. First of all, this is pseudomembranous or thrush. It could be erythematous, as I mentioned before, that not only white patches could be present, but it could be only erythematous area in the oral mucosa, or hyperplastic, like in this case. Honestly, it looks like hyperkeratosis or leukoplakia. Sometimes in case of candidiasis we can see cheilitis angularis, infection frequent with Candida albicans involving on one or both mouth commissures or corners, and you can see this typical clinical sign. So it can be associated with candidiasis. And the last group of white and red lesions of oral mucosa represent lesions with malignant potential. Lesions with malignant potential in oral mucosa include a lot of diseases. First of all, this is lichen planus, chronic hyperplastic candidiasis, leukoplakia and erythroplakia. About all these diseases or conditions we will talk now. So, lichen planus. represent chronic skin and mucous membrane disease. The etiology of disease is unknown, possible autoimmune disease. Prevalence of oral lichen planus is 1 to 2%. It's estimated that more than 1% will be able to develop into an oral cavity cancer. The time of this transformation, like a rule, is 5 years. Different types of oral lichen planus we distinguish. First of all, 6 classic forms. This is reticular, plaque, atrophic, erosive, bullous, and ulcerative. And clinical oral lesions of oral lichen planus include white patches, erythematous, bullous, and ulcerated. Clinically, lichen planus represent whitish plaques in the surface of oral mucosa, and I want to focus your attention in the clinical manifestation. It's not only just whitish plaque, the appearance of network you can see here. It looks like network, or here in the tongue or in gingiva. It's very important to differentiate lichen planus and lichenoid reaction. Lichenoid reaction is related with reactive processes related with different drugs or other causative factors. And when we talk about clinical differential diagnostic, sometimes it could be very difficult to distinguish these both conditions. For a proved diagnosis, it's necessary to take a biopsy. The most common difference between these two conditions, when we talk about lichen planus, because this is autoimmune, one of the possible cause of this disease is autoimmune nature, so like a rule, the disease is bilateral. When we talk about lichenoid reaction, like a rule, this is unilateral lesion. Histopathologically, lichen planus is characterized by hyperkeratosis and or atrophy of epidermis, variable degree of acanthosis, degeneration of basal epithelial cell layer. It represents presence of apoptotic cells, which we name like civat bodies. And very common histopathological changes include intense subepithelial infiltration of lymphocytes in a band pattern. So here you can see the most common morphological features of lichen planus. So here in the surface of epithelium we see keratin layer. Normally when we talk about non-keratinized squamous cell epithelium, this layer is absent. So in case when we see this layer, we name this process like hyperkeratosis. The next very typical morphological appearance of lichen planus is acanthosis. Acanthosis represents thickness of epidermis, first of all, related with increased proliferative activity of epidermocytes. In the dermoepidermal junction, we can see apoptotic cells. First of all, in the basal layer, they represent pinkish apoptotic cells, which we name civat bodies. And as you can see here in this slide, there are very severe subepithelial inflammatory infiltration in band-like pattern. It means just under epithelium very severe, like band-like infiltration. So again, other picture, morphological picture of lichen planus. You can see apoptotic cells in the basal layer in the area of derma-epidermal junction. If you remember this clinical picture I showed you before, like example of lichenoid reaction. So as you can see morphologically, lichenoid reaction and lichen planus, they have absolutely similar morphological features. We can see hyperkeratosis, acanthosis, thickness of epithelium, apoptotic cells in the basal layers, and subepithelial inflammatory band-like infiltration. Again, how to differentiate these both conditions, this both pathological process? First of all, clinical information is very useful for pathologists. I mention again that when we talk about lichen planus, like a rule, this disease is bilateral. Sometimes clinicians use the term symmetrical appearance of pathological processes or lesions in lichen planus. When we talk about lichenoid reaction, this is unilateral and asymmetrical lesion. Other lesion with malignant potential is chronic hyperplastic candidiasis. It's estimated that approximately 15% will develop into a dysplastic lesion. And so here in this clinical picture you can see clinical manifestation of chronic hyperplastic candidiasis. Morphologically, we will see the same typical features related with presence of Candida hyphae in the epithelium. Again, we can see severe inflammatory infiltration, but for prove the presence of candidas in the epithelium, we have to use additional pus staining, and this staining help to visualize the hyphae of Candida. Leukoplakia. We discussed with you about leukoplakia in the first semester. So, leukoplakia is a clinical term indicating a white patch or plaque of oral mucosa that cannot be rubbed off and cannot be characterized clinically or histopathologically as any other disease. It's very important to understand that leukoplakia represent just clinical appearance of lesion. We can translate leukoplakia like white plaque, leuko, white plaque. The term leukoplakia should be used to recognize white plaque of questionable risk, having excluded other known diseases or disorders that carry no risk for cancer. So, here you can see the example of leukoplakia. Again, in these clinical pictures we can see just whitish plaque in surface in different places of oral mucosa, for example in the tongue, in the gingiva, in the buccal mucosa. For approve the diagnosis, for understand the reason of this whitish plaque in the surface of oral mucosa, we have to do a biopsy. In this slide you can see histopathological grading of leukoplakia. It could be hyperkeratosis or and epithelial hyperplasia. It could be light, moderate, severe dysplasia. It could be carcinoma in situ, and finally leukoplakia clinically can manifest like invasive cancer or carcinoma. Clinical diagnosis leukoplakia or keratosis. Histopathologically we will see just hyperkeratosis hyperkeratosis, increased amount of keratin, and in this slide you can see other very typical morphological signs like hypergranulosis, increased thickness of granular layer, but without dysplasia. Minimal risk for subsequent cancer development is in this hyperkeratosis. You can see the percent 1 to 5. Again, keratosis in oral mucosa represent the presence of keratin in the surface of epithelium. Very often we can see hypergranulosis, thickness of granular layer of epithelium, without atypical features in epithelium. Clinical diagnosis leukoplakia keratosis. When we talk about epithelial hyperplasia without dysplasia, minimal risk for subsequent cancer development. Again, so we don't see any atypical changes in the epithelium cells. Clinical diagnosis leukoplakia keratosis could be associated with histopathological diagnosis of dysplasia. We classify dysplasia like mild, moderate, and severe. It depends of spreading of dysplastic cells. In case of mild dysplasia, we will see dysplastic cells located first of all in the basal and suprabasal layer. When we talk about moderate dysplasia, dysplastic cells are found not only in the basal or suprabasal layer, but in more superficial layer of epithelium. And in case of severe dysplasia, whole layers of epithelium is involved in dysplasia. So in all layers of epithelium we can see dysplastic epitheliocytes. According to scoring system, we distinguish different sign of dysplasia. So this scoring system recommended by World Health Organization include different architecture criteria and cytological criteria. As you can see in this slide, architecture in case of dysplasia include irregular epithelial stratification, loss of polarity of basal cells, drop-shaped red ridges, increased number of mitotic figure, abnormality, superficial mitosis, premature keratinization in single cells, we name this process like dyskeratosis, and keratin pearls within red ridges. When we talk about scoring system and cytological changes, first of all, we talk about abnormal variation in nuclear size, anesonucleosis, abnormal variation in nuclear shape, nuclear pleomorphism, as you can see in this picture. The nuclei are very dark and enlarged, and the shape is absolutely unusual in comparison of normal epithelial cells. Abnormal variation in cell size, anisocytosis, abnormal variation in cell shape, cellular pleomorphism, increased nuclear cytoplasmic ratio. I hope you remember well that normally the nucleus is less than cytoplasm, but when we talk about dysplasia, we will see increased size of nucleus first of all in dysplastic cells, increased nuclear size in general, atypical mitotic figures, increased number and size of nucleoli, and hyperchromasia. Hyperchromasia, this is dark color of nuclei in the cells, related with increased proliferative activity of cells first of all. So, how to differentiate hyperplasia and mild dysplasia? You can see that in mild dysplasia we will see some architectural and cytological listed below features, but these features occur in 1/3 part of epithelium. So first of all, we will see these changes in the basal and suprabasal layer of epithelium. Moderate dysplasia, when 2/3 of epithelium involved in dysplastic process, and these dysplastic epithelial cells we see not only in basal layer but in the more superficial layer of epithelium. And in severe dysplasia you can see that in all layers epithelial cells demonstrate severe dysplastic features. In case of severe dysplasia, we can talk about carcinoma in situ. If you remember well from the first semester, carcinoma in situ represent non-invasive carcinoma. It means that cancer is developed but without invasion of basal membrane. For that, we can say that this form of carcinoma represents non-invasive localized form of cancer. In carcinoma in situ, we can see that severe dysplasia occurs not only in basal layer but in superficial layer, and as you can see in this slide, there are a lot of cells with big nuclei and abnormal shape of nuclei, very dark chromatin, hyperchromatism, we name this process. So all these features are typical for severe dysplasia and carcinoma in situ. Prognosis of leukoplakia. As you can see in this slide, 17 to 25% display a dysplastic epithelium. When the lesion is on the floor of the mouth, then up to 45% have a dysplastic epithelium. 4 to 17% develop in the cancer. The risk of developing malignancy at lesion sites is 5 times greater in the patient with leukoplakia than in patients without leukoplakia. And 30% of leukoplakias can regress if habits are stopped. It's very important, it's very useful to explain to our patient about this. The last lesion with malignant potential of oral cavity is erythroplakia. So erythro, it means red. For that we use erythrocytes. The rule is the same. Erythroplakia represent clinical term indicating a red patch or plaque of oral mucosa that cannot be rubbed off and cannot be characterized clinically or histopathologically as any other disease. Again, erythroplakia, like leukoplakia, represent just clinical symptom of lesion in the oral mucosa. Often the epithelium has dysplasia or carcinoma in situ. You can see in 80 to 90%. 23.4% will develop till an invasive carcinoma. So, according to this information, erythroplakia is more dangerous than leukoplakia, according to these clinical features. So, clinical manifestation of erythroplakia, you can see in these clinical pictures. In the arrow, we see reddish plaque in the whitish base of in the oral mucosa. The same here. In this picture, I think it's very suspicious for cancer and invasive carcinoma, first of all. So morphologically, in case of erythroplakia, we can see the same features. First of all, severe dysplasia, because in this picture we can see that all present in the slide epithelial cells are abnormal, are atypical, and this atypia, we see this atypia not only in the basal or suprabasal layers of epithelium, but through the whole layers of epithelium. Erythroleukoplakia, other very interesting and very important lesion of oral mucosa. It's true that sometimes we can see mixed clinical manifestation with area of leuko and erythroplakia, like the pictures present in this slide. Erythroleukoplakia represent heterogeneous presentation of combined red and white surface changes. What should we do in this case? You have to memorize once-ly. It's necessary, it's recommended to take a biopsy from different site of clinical manifestation. For example, here you have to take a biopsy from this red area and this excess tissue growing with whitish color. The same here. You can see the difference in clinical presentation. For that, you have to take multiple biopsies from different clinical presentation. You can see in this slide that it's recommended to take a biopsy from whitish area and from reddish area in the same patient. Clinically, it's recommended active follow-up each 6 months and biopsy in areas with recent changes. What about risk of malignant potential of all these conditions? Lichen planus has low risk of malignant potential. Chronic hyperplastic candidiasis has low risk of malignant potential. When we talk about leukoplakia, moderate risk, and very important to memorize that in case of erythroplakia, the risk of malignant potential is very high. And the last part of lecture we will focus in oral cancer. Oral cancer usually represents small but indurated ulceration on the rim of the tongue. Very important to memorize that, like a rule, when we talk about clinical manifestation of oral cancer, it's painless, no pain. It leads to what? It leads to late admission for medical assistance. When we talk about gender predisposition, like a rule, oral cancer is typical for men older than 50 years of age and smokers. Here in this slide you can see the list of the most typical risk factors. The first place is tobacco, then alcohol, diet and nutrition, ultraviolet light, fungal and viral infection, bad habits, chronic irritation, immunodeficiency or immunosuppression, and occupational risk. For many years, surgery and or radiotherapy has been used as a curative modality. The aim of treatment depends on the stage of presentation. In case of early lesion, can completely be treated by surgery or radiotherapy. In case of late lesions, a palliative treatment is advocated. This could be in the form of radiotherapy, surgery, or both. Rehabilitation of patient after surgery could be either surgical reconstruction, prosthetic reconstruction, or both. This aimed at restoring aesthetic, function, and speech. All patients must be placed on lifelong review of about 6 monthly intervals during which risk factors should be continually assessed. Thank you for your attention, and I hope that you will learn and keep calm when you will study oral pathology.